Morning, good afternoon, good evening, clinical problem solvers. Nice to see everyone after a long break. As some or many of you might know, I was moving and starting a new job at UCSF. So I see Robbie and Jack and Doug and all our CP solvers, and Madalena also, our CP solvers friends and visitors to San Francisco. So that's why I've been away for a while and busy getting started in my new job, having a lot of fun and seeing a lot of great neurology and working with a lot of great residents. So good to be back. And hopefully this evening time for today is what worked, just to get one at least on the calendar, since I don't think weekly every day during normal work hours is going to work as well for me anymore, to get one on the calendar, and hopefully one that will allow some of our colleagues in other time zones to join without it being the middle of the night, as our old time was. So we'll try to do one of these about once a month. It'll probably be a little irregular because I'm working between two hospitals and still figuring out what all I'm doing here, but having fun and excited to be back here with you all. And great to see a big bunch of folks here, 17 people, which is I think a good haul for a late announced Neuro VMR. So did anyone bring a case they were hoping to discuss? And was anyone hoping to discuss a case? Ideally two people, one identifying as a woman and one identifying as a man. Anyone?
I have a case if you guys don't have one.
Okay, John has a case. Madalena has a case. Who else has a case? Should we do several cases at once? When our clinic gets busy and two residents come to staff at the same time, I say, okay, left ear, right ear, let's go. But we don't actually do it because that would be pretty difficult. Great, we have potentially two cases. Did anyone want to discuss a case in particular? This is the harder question.
I'm open to anything. So if a case is needed, I can present. If we need a discussant, I'm also happy to discuss. All
right. Well, we have three people in one configuration of two cases, one potential discussant. Was anyone else hoping to present a case or discuss today who maybe hasn't had an opportunity before with the morning time or? All right. In that case, Madalena, Valeria, and John, in whichever configuration you would like, since I know all three of you have cases and at least two of you would like to discuss. I'll let you play virtual rock, paper, scissors and decide who wants to do what.
I would prefer to do you have a preference?
I would prefer to discuss, actually.
Okay, Valeria is a discussant. John, Madalena, other.
John, what do you prefer?
I guess present. I mean, it's not too big of an issue either way, but.
Okay.
I have a foster cat, so you're gonna hear him sometimes. But.
All right, is that a clue? Toxoplasmosis? No. Okay. That okay with you, Madalena? We'll save your case for another time.
Perfect.
Or we are having so much fun. We want to do two cases since we don't know when the next one will be. I'm here for it. It's early in California.
I'll save my case for next time so that we have the whole time to discuss.
Fantastic.
It.
All right, let's do it. So someone's going to do teaching points and scribing and all that good stuff. And while we're getting that set up,
Maria's got it.
John, Valeria, Madalena, I think everyone knows you all, but do you want to introduce yourselves? Just tell us where you're joining us from, and then we'll get started.
Sure, I could start. My name is John Acquaviva. I am from LECOM. I'm in Erie right now, and just, I guess, last month submitted application to a neurology residency.
Woohoo! Congratulations.
Thank you.
And great. Madalena and Valeria.
Yeah, I can go. So hello, everyone. My name is Madalena. I also go by Maddie, so you can call me either one. I am on a research year between my third and fourth year of medical school. So I'm currently in San Francisco. And I actually plan on applying into internal medicine residency, but I really love neurology and want to keep learning. So I'm going to tune into as many of these as I can.
Perfect. And if you happen to change your mind, we will welcome you to neurology with open hands.
Yeah, for sure. Hi, everyone. I'm Vale. I'm a medical student from Peru, currently doing a clerkship in Alabama, and hopefully a future neurologist. Really excited to discuss again.
All right. So let's go ahead, John. Do you want to give us just the chief concern, chief complaint, and we'll go from there.
It is diplopia.
Diplopia, excellent. All right. See, big smiles from Valeria and Madalena. We're playing a game show. Big smiles from Madalena and Valeria on diplopia. So we'll let you both take a crack at it. Valeria, do you want to tell us what came to mind or why you're smiling so broadly for this chief concern as I am?
Yeah, I think for sure it's one of my favorite differential diagnoses just by learning from you, actually. So yeah, I definitely think diplopia would make me think of a misalignment of the muscles of the eye. So in that case, I would like to know if it's monocular or binocular diplopia, in which case you can follow the whole pathway of vision and muscle movements, so to speak. And usually I think the binocular diplopia is the one in which there's this misalignment of the eyes. And, going back from the nuclei of the cranial nerves that control the muscles, it will go to the brainstem, and then you can see the nerves that go out of the brainstem nuclei, in which case, you can have something that happens to the nerve, like a compression or a stroke, and then you can the nerve connects to the muscle via the nerve muscle junction. You can have diplopia because of myasthenia gravis, for example, and then the muscle itself can have a myopathy. Like, for example, I guess Graves' myopathy could cause diplopia potentially, and then you can have something happening to the muscle in a way, like, I don't know, I've seen patients disrotation that have something in their eye, like cellulitis or an abscess there that can also present with diplopia. So I think binocular diplopia is, the first thing that comes to mind, but then you have monocular diplopia as well, which I think I probably leave more to, or refer more to, neuroophthalmologists, because I do think it's more to the local system or the internal parts of the eye, which are more intimidating to me, honestly.
Brilliant, Valeria. The only thing I'll correct is you said future neurologist. I think we're going to just call you a neurologist because that was phenomenal. So let me highlight a couple of great points. This monocular versus binocular, right? When we think of diplopia, we think, oh, the patient has double vision. And so we can all do this if you gently just, touch your eyelid on one side so your eye can't move and try to move your eyes around. You'll see that things split apart, right? Because the brain is used to getting the information in a certain way, hitting the retina in the same certain places on both eyes and interpreting that as something being in one place in space. And if you confuse the brain by moving the eyes into misalignment, then things will appear double, right? And so that's binocular diplopia, because if the eyes are misaligned and the patient covers one eye and says, oh yeah, now I just see one, now I just see one, now I just see one, you say, oh, both eyes are normal, but somehow they are misaligned. Whereas monocular diplopia, the patient covers one eye and says, oh no, it's double. It must be some problem with that eye itself, some sort of, I think usually lens problem where, there's some refraction or something of the light. Again, as Valeria said, this is an ophthalmology thing. So this is helpful for us to at least say, oh, this is actually not us. This is the ophthalmologist. There's something wrong with the lens or ocular apparatus such that the images are getting split in a way that the patient can describe as double or blurry or something. Whereas true diplopia or binocular diplopia would be from misalignment. And Valeria took us through that pathway, right? Well, how do the eyes move? They have muscles, and those muscles are controlled by cranial nerves, and those cranial nerves arise from cranial nerve nuclei in the brainstem. So anywhere along there, we could have pathology that, if it was on one side or if it was asymmetrical in some way, could cause the eyes to be misaligned and not moving in a conjugate way. So that's phenomenal. Anything to add, Madalena? And then otherwise I can add a couple of tiny things.
I think that was Vale just walked through such a helpful approach to me, dividing it, is this monocular or binocular. And I really liked how you walked through the anatomy, because as what comes up in all the VMRs, the differential is the localization times the time course. So I think Vale walked through kind of the localization. Is this a brainstem issue, a nerve issue, neuromuscular junction, muscle? And then, of course, more information as we'll want to know kind of the time course. So has this been, chronic diplopia? Is this more acute? And I think, Vale walked through some more autoimmune diseases that can cause this, like a myasthenia gravis. And you can also think of, potentially, if this is a more chronic process, could there be a malignancy that's causing a mass, compressing one of these structures? So I think just adding on to the amazing kind of anatomical approach that Vale walked us through, I think the time course will be really valuable.
Yeah, perfect. So both of those are important, right? And we often think in neurology, oh, these structures, right? You think, is it a cranial nerve nucleus? Is it a cranial nerve? Is it one or more of the muscles? And I'm glad Valeria and Madalena both reminded us of myasthenia gravis also, right? The neuromuscular junction, which we can't really see, right? Unless we have electron microscopy. But so we sometimes think, oh, it's nucleus nerve muscle, but that neuromuscular junction is important too. And I don't know the percentage, but the large majority of patients with myasthenia gravis will present with some type of ocular symptom. We learn about ptosis, but they can have any type of extraocular muscle weakness or paralysis, and they can sort of imitate any of the cranial nerve palsies or otherwise. So sometimes people will get faked out and think, oh, the patient has, I won't say which type of lesion because I want to go through those in a moment, but patient has this type of weakness, it must be this muscle or this nerve. And sometimes lots of imaging, lots of studies, and then someone says, oh, when I saw them, it actually looked more like this. And you say, oh, it's fluctuating. Could it be myasthenia? You'd like to see ptosis there to help you, but you don't always see that. So myasthenia. And then Valeria mentioned thyroid eye disease, another one that we don't see too much in neurology. I guess they find their way to the ophthalmologist directly, or maybe people catch hyperthyroidism early, or internists can tell me if you're still seeing a lot of thyroid eye disease. But I think the teaching is that thyroid eye disease tends to affect the rectus muscles more than the obliques for some reason. And I think particularly the inferior rectus, but even though it's a systemic disease, you can get it on one side or the other, or in muscles. And then it's not a question of weakness misaligning the eyes, but restriction, where that inflamed muscle is not allowing the eye to move in a particular direction. I'm talking a little fast because there's so much to talk about here, and I know we have a whole case, but I want to tease a little bit more apart here of this important anatomy, because it's going to set the stage, I think, for the exam. And before we do that, as Madalena said, important to think about the time course. And here, this is where these are very much linked, right? Because you might say, well, if it was sudden, I'd be worried about a stroke, but you could get a stroke in the brain stem, right? But you shouldn't be getting a stroke in a muscle or a neuromuscular junction. So when we know the place of the lesion, it's also going to circumscribe a little bit the what, right? So the where will help us with the what. The neuromuscular junction, there's not too much stuff that happens there, right? You have myasthenia gravis, you have Lambert-Eaton, which tends not to affect actually the extraocular muscles, but more the skeletal muscles. Myasthenia can do both. You have botulism, which is extremely rare. There's not too many diseases there. If you localize it there, you can get a pretty narrow differential diagnosis, where if you do say, oh, this seems to be in the brainstem, then depending on the time course, right, it could be stroke, could be tumor, could be otherwise. And then Valeria mentioned also, just to add on there before we add a few things, the orbit itself, right? We talked about thyroid eye disease affecting the muscles, but there's a process in the orbit. The patient might have some restriction, and you can get all sorts of things in the orbit. You mentioned orbital cellulitis. I think there are various orbital tumors. There's orbital, there's some type of orbital pseudotumor I've heard of, which I think is some sort of inflammatory thing. Anyway, all sorts of things in the orbit. Okay, we sort of have implied, but haven't officially said, what are those cranial nerves, by the way, that we're alluding to that control the muscles of the eyes? Either of you want to tell me one or more of those and which extraocular muscles they innervate?
So cranial nerve 6 innervates the lateral rectus muscles, and then cranial nerve 3 does the rest of the extraocular muscles, I believe.
Pretty close. There's one more nerve in the.
Oh, 4, right?
Yeah, the one people least like to think about, because actually the muscle it innervates does the most complicated thing, right? So perfect, Madeline. So 6 does the lateral rectus, and I like to think about eye movements with my hand. So what does the lateral rectus do for us?
Abduct.
Yeah, abduct, right? We usually say
Abduct,
AB and AD, especially over Zoom, so we know what we're saying, because abduct and adduct say the same. But abducts, right, takes away from the midline. So if I'm doing this, I'm looking to my well, it's very hard with the zoom reverse. I'll just say looking to this side, right? It's the abducting eye away from the nose. That's cranial nerve 6, lateral rectus. Cranial nerve 4 does one muscle. Which one is that?
Superior oblique, I believe.
That's correct. And then everything else, so inferior oblique and then superior, medial, and inferior rectus are done by 3, as well as levator palpebrae and the parasympathetic to the pupil. Excellent. So that means we have cranial nerves 3, 4, and 6. We have the 4 rectus and 2 oblique muscles in each eye. If those become relevant, we'll get into the superior oblique because that's a longer discussion, how it works and what its actions are. And we have their cranial nerve nuclei, Valeria told us, and where do those live in the brainstem, 3, 4, and 6?
Yeah, so I love the rule of fours. It's probably my favorite thing. And so the midbrain will have the first 4s, so including the third, and then the other from like 5 to 8, you will have it in the pons, and then in the medulla you will have the last 8 pons. So there will be midbrain and then the pons for the 3,
Perfect.
4, and 6.
Yeah. So we like to say midbrain 1, 2, 3, 4, pons 5, 6, 7, 8, medulla 9, 10, 11, 12. There are some exceptions. We won't get into them this time. 1 and 11 don't go to the brainstem at all. 5 is at all 3 levels. 8 straddles the pons and medulla, all kinds of little exceptions. But for this, everything works. 3 and 4 in their midbrain, and 6 is in the pons. And then we need to move our left and right eye together, right? So how do those nuclei on the left and on the right talk to each other? So for example, for horizontal gaze, if I want to look left, I need my left lateral rectus by 6, my right medial rectus by 3. How do those know to talk to each other? Either of you remember, if you're taking a step exam soon, this is a very popularly tested, Maria is confirming, structure.
Yeah, like it causes the internuclear ophthalmoplegia. I think it's MLF or the and then there's also the P something that connects the third and the 6th, so that they conjugate. Case.
Excellent. Yeah. So we'll focus on horizontal gaze. That's the easier one to understand. If this patient happens to have vertical diplopia, we'll talk about that, though it's more complicated to understand. So, right. So to move in horizontal gaze, we need lateral rectus on one side and medial rectus on the other side coordinated. That means we need 6 on one side and 3 on the other side coordinated. So their nuclei need to talk to each other. And they do that through a structure called the MLF, or medial longitudinal fasciculus, not to be confused with medial lemniscus, which is the dorsal column's pathway once it's in the brainstem. Medial longitudinal fasciculus talks between 6 and 3 on opposite sides. In truth, we learn it that way, but it's actually a sort of highway that actually connects 3, 4, 6, and 8. That's how we underlie the vestibulo-ocular reflex that lets our inner ear talk to our eyes, so that it's sort of like a highway with exits for nuclei of 3, 4, 6, 8, so that the extraocular or the ocular motor nuclei, meaning 3, 4, 6, can all talk to each other. And right, if you have a lesion of that, and if that becomes relevant, we'll talk about it, then 3 and 6 can't communicate on the 2 sides, and that gives us a particular condition called internuclear ophthalmoplegia, a lesion between the 2 nuclei, paralyzing a particular eye movement, internuclear ophthalmoplegia. And again, if that becomes relevant, we'll get in there since we'll get into it more deeply since we've already spent a lot of time laying this anatomy out. So you have the nuclei of 3, 4, and 6 that talk via the MLF, the nerves of 3, 4, and 6 that come out to innervate these muscles at the neuromuscular junction. And if you have binocular diplopia, it has to be one of those structures involved to get a horizontal misalignment. Vertical is more complicated, and if that's relevant, we'll get into that. But that's the only way you could get disconjugate gaze. Valeria was thinking of the PPRF, the paramedian pontine reticular formation. And that's supranuclear, meaning that's what tells the eyes in the brainstem go left or go right. And then that's commanded by the FEF, the frontal eye fields, which are the sort of ultimate command. So if you say, I would like to look to the left side, your right FEF, since your right brain's controlling everything on the left, seeing the left visual field, et cetera, says look left. The right FEF talks to the left PPRF, and then that talks to the left 6, which talks to the right 3 through MLF. But if you had a PPRF or an FEF lesion, you'd have a conjugate gaze palsy. You would not have diplopia because you're lesioning a structure that moves the eyes together, right? So you've seen patients with a left MCA or right MCA stroke, full territory stroke, paralyzed on one side and looking with their eyes and often their head away from the paralysis or toward the side of the lesion with the FEF, looking toward the paralysis and away from the lesion. Am I saying that right? Because it's so uncommon. Looking, yes, toward the paralysis and away from the lesion with the PPRF, though you almost never see that. And we're all thinking about it and squinting because it's harder to think about. It's basically because the corticospinal tract has not yet crossed in the pons. So if you had the left corticospinal tract, you'd be weak on the right. And if the patient has gotten the left PPRF also, they can't look left because the brainstem does ipsilateral step. So their eyes will be deviated to the right, looking at the paralysis away from the lesion, but you almost never see that. But none of those would cause diplopia because you have a conjugate gaze palsy. So FEF, PPRF, those are supranuclear lesions, meaning sort of above the hierarchy in the nuclei, not going to cause diplopia. You need a nuclear lesion, nerve lesion, muscle lesion, neuromuscular, junction lesion, or MLF lesion to get diplopia, horizontal diplopia. I keep qualifying because vertical. If that's what John has waiting for us, we'll have to add some more complexity to this. Excellent. So we have a great framework now. And as we're talking to the patient and getting a sense of the timing of this, and if they've noticed that objects are separated horizontally versus diagonally versus vertically, if it's worse close up or far away, what their past medical history is, all these things are going to be clues for us in the history. But of course, the gold mine will be on the exam, seeing what's actually affected. And then I think if people are looking to see this thing I just described, which is hard for me to just do with my finger in the air, I think I have a tutorial on horizontal gaze if someone wants to throw it in the chat to see. I think I have some diagrams with it, but I'm not sure. It might just be description. If not, I'll send some around. Okay. So thank you for that provocative word, John, which gave us all smiles and a fun discussion here. Can you tell us what you learned on the history from this patient?
Yes, I can. So on the first outcut, a 55-year-old woman who presents with a past medical history of COVID-19 twice and colonic polyps and really nothing else, presented after 3 days of acute onset double vision. She pretty much woke up 3 days ago with double vision just in the morning. It's just kind of how it started and hasn't resolved since. She actually went to the optometrist the following day, and they found that her diplopia, when putting a prism in front of either one of her eyes, fixed itself. And she was very persistent. So she asked, because her daughter is actually getting married that weekend. So she asked her optometrist if there was a way to temporarily fix this. And he actually taped her glasses, one of her glasses eyes, so she could have normal vision. So that's kind of how she presented with the taped glasses. That following day after she went to the optometrist, she noticed some numbness and tingling in her hands, feet, mouth, and tongue. The next day after that, she noticed that she felt mildly unsteady on her feet and that she was having difficulty controlling her arms and hands. She started spilling tea and she couldn't turn on like a twist lamp. These new coordination symptoms, addition to her symptoms, are what prompted her to come to the emergency department after the diplopia. And that's the end of that aliquot.
Okay, lots of stuff there. I think you're up, Madalena, since Valeria started last time. Feel free to take any one part of this or multiple parts or the whole and tell us what's running through your mind at this point.
Yeah, okay. So we have a lot of interesting information here. So I think I'll just start with, well, first of all, we have the time course, which is helpful. So this is acute, and I think the kind of the age range of this patient, the fact that they're 55 years old, I think, there's not so much we can jump to right away, but just something that I'm tracking. And so what's interesting is that Vale, kind of the initial branch point she talked through was like, is this monocular or binocular diplopia? So I'm trying to figure out if we have enough information here to put it in either of those buckets. So the fact that the diplopia was temporarily fixed by taping shut one glass eye, that makes me think that this is more of a binocular issue here. So I'm not sure kind of what, I think from there, because now that we were able to focus more on that bucket, we can kind of think through where the localization piece. But now it's interesting that we have additional data about numbness and tingling, and then unsteady in the feet. Seems like unsteady gait here. So I'm curious, is the unsteady gait, is that kind of related to the sensory abnormalities, or is that related to some kind of weakness? So I think that's something that I want to tease out in the neuro exam. Is the unsteady gait related to weakness, or is it all related to numbness and tingling? And what I'm not sure here is, is the numbness and tingling part of the same process that's causing the diplopia, or is it a different process altogether? We talked about things that are very common that can cause numbness and tingling, or diabetic neuropathy, but there's no history of that. So I think that's just a big question in my mind at this point. Like, are those two processes related, or are they separate? Vale, what are you thinking with this additional information?
Yeah, I agree. I for sure think this is the binocular diplopia, and I don't know. I feel like the fact that she's had all these sensory and potentially motor symptoms in other sides of her body makes me think more about a neuropathy. And in that case, I will think about, because of the time course that is acute, I will prioritize inflammatory and infectious causes. And in the infectious causes, for example, thinking about viruses that really like the cranial nerves, like VCV, and then bacteria, also like Lyme, that really like the cranial nerves. And then so I don't know if it will be too early, and then to like frame this as a polyneuropathy, or like a mononeuritis multiplex potentially. I don't know the pattern of if there's difficulty controlling upper extremities, means that one of them is weak, or if this patient has maybe like a movement disorder that doesn't allow her to use her extremities appropriately, on top of a neuropathy that could be explaining her numbness and tingling, or could she have a metabolic cause, like for example, I think it will be hypercalcemia that could cause numbness or tingling, especially because it's around her mouth, which is a little weird, I think, for a neuropathy type of picture. So I'm not sure if I've just been too, like I'm closing my DDX too soon, thinking about a neuropathy just by the HPI.
Yeah, great thoughts from both of you, right? First, to highlight things that Madalena said. Yeah, the diplopia is fixed by covering one eye, and this is something you can actually, the prisms, I don't remember exactly the physics, but by sort of changing the angle at which things are coming into that eye, the optometrist or ophthalmologist can measure sort of, oh, they need this, they have all these prisms, they can just check until the images are back to normal and say, oh, this is the amount of prism diopters or whatever the unit is that is needed to realign the eyes. And for patients who will have chronic misalignment, they can actually grind the prism into the lens, whatever that means, but that's how they say it. And you can actually sort of fix it. Or short term, patients say it's so double, does it resolve when you close one eye? Well, then we're just going to put tape over the glasses on that side, or wear an eye patch. Person's going to a wedding, maybe they don't want to wear an eye patch, just have them, doesn't matter, it could be either eye, right? And switch back and forth. So this is diplopia, and it's binocular. So we know something is going on along that pathway. And I like how you framed, Madalena, that, hey, now there's something else going on. Is this all part of the same thing? Is this something different? We have to wonder about that. And so one thing that can be helpful on the neurology side, we always come back to localization. Is there any way you both could sort of unify? So you both said with numbness and tingling that, from what we're hearing, sounds symmetric. It's hands, feet, mouth, tongue, as Valeria said, would be not a super common neuropathy syndrome, but every part of the body has nerves going to it, so it could be. But you both sort of zeroed in on, this sounds kind of neuropathic. Is there any way to unify something going on with the eyes and something going on with the nerves together? Just like something going on with the peripheral nerves, yeah.
I think
you sort of hinted at this, Valeria, but go ahead, yeah.
Sorry, I now I think it's probably wrong, but just something that Maddie mentioned about diabetic neuropathy, because, for example, diabetes can also compromise cranial nerve 3. But I don't know. I don't know if that will be a little weird so that the onset of peripheral neuropathy in the hands and feet are kind of acute.
Yeah. So yeah, a couple good points, right? So when we hear about neuropathy, common things being common, diabetic neuropathy is certainly very common. But yeah, I'm glad you said a point that I wanted to bring out was that this would be really fast for diabetic neuropathy, right? That's usually a chronic condition. It's axonal, right? We won't go down that rabbit hole this time, but we did in the one that was recently podcasted about length dependence, right? So if we have mouth, tongue, hands, feet all at once, that doesn't sound length dependent. But patients with diabetic neuropathy have this length dependent axonal neuropathy, meaning by the time they come, they've had symptoms in their feet for a long time and they're kind of very slowly progressing. So time course and distribution don't quite fit for diabetic neuropathy, but neuropathy is still on the table. And then while we're talking about diabetes, you made a great point. There are actually diabetic cranial neuropathies. And for some reason, the cranial nerve 3, 4, or 6 tend to be not uncommonly affected. So this is like a stroke of a cranial nerve. It's a microvascular palsy, and the patient develops sudden onset or acute onset diplopia. There can be some pain associated with this, head pain or pain near the eye. And you examine them and they have an isolated cranial nerve palsy. And so that can be 6, that can be 4, that can be 3. When it does affect 3, it's a little bit unique while we're talking about this. You said a lot of good reasons, Valeria, why this doesn't quite make sense. The patient doesn't have diabetes that we know of, and the neuropathy seems to be ticking along pretty fast. But there's a special feature of how this tends to affect cranial nerve 3 most commonly that clues us into this being diabetic. Either of you, it's a little bit guess what I'm thinking, for which I apologize, but either of you know, either of you want to guess what I'm thinking.
So the fact that it's like a microvascular injury, so it will affect the center of the nerve first, so it will cause ptosis, and probably the eye will be out and down, which is not the case here.
Well, we don't know yet, but you said everything.
Well,
but there's one more piece that helps you know that it's this and not a compressive third from an aneurysm or something like that.
Oh, like the pupil. The pupil is not affected.
Tell us. Yeah. Go ahead. Yeah, tell us.
Oh, sorry. That the pupil is not affected.
And do you know why?
Because the parasympathetic nerves are peripheral, so they wouldn't be injured by the microvascular because the vasa vasorum is deep.
Excellent. Yeah. So the third nerve is actually a bundle of fibers. And the third nerve nucleus actually is a complex. That there's a superior rectus subnucleus, inferior rectus subnucleus, medial rectus. If you like neuroanatomy, it goes on and on and on and on. If you don't, it also goes on and on. And those subnuclei are sending their axons into the third nerve. And as Valeria said, the pupilomotor fibers are running on the exterior surface of the nerve. So compression tends to hit those first, whereas the microvascular thread that's getting the core of the nerve tends to affect the motor fiber. So if you see a pupil sparing third nerve palsy where the eye's down out, plus minus ptosis, the pupil is reacting perfectly. Some people will say you don't even need to get any scans in that patient. This came up recently on rounds and we looked into it, and like everything in medicine, well, it's not a perfect rule. There's some compressive ones that compress the side of the nerve that doesn't have the pupilomotor fibers and it looks pupil sparing, but it's compressive, or there's some diabetic microvascular, I should say, we learned also microvascular because we saw one in a patient that almost certainly had this diagnosis, and diabetes was well controlled. And we learned, yeah, hypertension can probably do this as well, or some combination of the two. So, right. That was, I think, worth talking about because it's interesting, but for the reasons you both said, the fact that a diabetic neuropathy would be cooking along this quickly in the limbs. And if we're trying to invoke one process, it's a little hard to unify all of those, but I'm glad you brought that up. And had we not had all that interesting extra information John gave us on day 2 and day 3, and we just had diplopia, and we just had an isolated cranial nerve palsy, and the patient otherwise looked fine, we might be invoking one of those microvascular ocular motor nerve palsies. And when I say ocular, like that, and emphasize it as to distinguish from oculomotor, which is the third nerve, ocular motor 3, 4, or 6. Okay. Other thoughts on if we were to put this all together, could there be one localization to it? One lesion or one region of the nervous system or one type of nervous system structure that's being affected that could give us diplopia and numbness tingling?
I mean, I'm wondering if this, if we're focusing on the nerves, if that could be kind of a unifying issue here. So we clearly see that. I think Vale classified this as, a polyneuropathy or a mononeuropathy multiplex, and then potentially for the diplopia, could there be a lesion at kind of the nerve level causing that?
Yeah, perfect. I'm so glad you said that, because the cranial nerves are peripheral nerves, right? I think people forget because they're coming out of the brain that they're peripheral nerves, except cranial nerve 2. And you might remember, what's the only cranial nerve that tends to get affected in MS, which is a central nervous system demyelinating disease? Cranial nerve 2, right? Because the eye comes out of the brain in development that has central nervous system myelin. Patients with MS can get trigeminal neuralgia, but that's from demyelination of the entry zone in the brainstem, not from the nerve itself. But the other cranial nerves, aside from 2, so 3 and down, I think 1 I always forget, like part of it is technically peripheral and then part of it is central because you have the tract and bulb and all that stuff, but we hardly ever talk about that nerve. So let's just say 3 and below, they're all peripheral nerves, right? So if there's a peripheral nervous system process that's global, it could affect cranial nerves and the quote unquote peripheral nerves. The cranial nerves are peripheral nerves, but the peripheral nerves of the extremities. So what could we think about if we were thinking about a sort of global process affecting cranial and extremity peripheral nerves that's moving along at the pace of days? What types of things could do that? You were interested in time course earlier, Madalena. Do you want to?
Yeah, and I think Vale also mentioned this. So I would be concerned about the infectious bucket, especially given the time course. So this is 3 days, and John mentioned that the person has a history of COVID twice. I'm not sure when that was. I also don't know if there's this could be a post-COVID phenomenon, but I would, maybe just want to clarify if the history, prior to 3 days ago, did they have any preceding illness that could have, triggered a process like this? So, but in terms of kind of the big buckets of disease, I'd be most concerned of maybe an infectious process, like a post-infectious process, or maybe even an autoimmune. But I think more of a malignancy, you wouldn't expect that to be as acute of a presentation. That's what's going through my mind. What do you think, Vale?
Yeah, I just wanted to highlight one of the comments in the chat, and multiple people have said it, but Lisa most recently I saw about the Miller-Fisher variant of GBS. I think that's a great thought, and definitely the inflammatory category would also fit with the acute time course. So thinking about that, because when they said that difficulty controlling upper extremities and they didn't say weakness in the upper extremities, I was like, maybe there can be some type of movement there that could also fit with maybe the facial-brachial variant of GBS or something like that. There's so many variants that I cannot keep up, but that's a great thought.
Yeah, excellent, right? So this is not sudden to think of stroke in any way. Stroke in the peripheral nerves, technically, that's, I guess, what you would see in a vasculitis, but that's usually painful and very uncommon to get a peripheral nerve vasculitis. But since mononeuropathy multiplex was mentioned, that's one subset of that, right? Mononeuritis multiplex, usually painful, and sudden sort of, and usually not all at once, sort of serial kind of different nerves in different places over time. So we move into the not sudden, but sort of acute, but not sudden. You thought about infections. Lyme can most commonly a 7th nerve palsy, but if you live in a Lyme endemic area, you can see it do all kinds of things. It can cause meningitis with cranial nerve palsies. Any actual cause of meningitis can cause cranial nerve palsies because the cranial nerves are in the subarachnoid space, part of the meninges, right? And then you would think of, so you'd think really in this category, infections, inflammatory, and then some type of toxic metabolic exposure affecting the nerves. I think there's some heavy metal poisonings that can give you acute neuropathy and mimic GBS, but uncommon. And then inflammatory, as you were saying, Madalena, could this be post-infectious, inflammatory, affecting the nerves? And then we talked about what that would be called, right? That would be called Guillain-Barre Syndrome, or Guillain-Barre Syndrome, as one of our French-speaking clinical problem solvers morning report colleagues told us. a while ago that that's the correct pronunciation is Guillain, but it's very hard to change after years of mispronouncing it. Guillain-Barre Syndrome. And there are many variants. We think of ascending paralysis, legs before arms, but the cranial nerves can be affected. They're peripheral nerves. And so what if we reframe this as, well, there's diplopia, so there's some ocular nerve or muscle problem. There's numbness and tingling, so there seems to be a nerve problem. And then we keep skirting, what are these difficult control upper extremities? Is that a movement disorder? Is that weakness? Is that some sensory problem making them hard to control? Is that ataxia? But if you start to add all of those up and say, hey, we have a sort of acute but not sudden process affecting cranial nerves and peripheral nerves, you might think of Guillain-Barre. And then if you examine this patient and see, oh, they have ophthalmoplegia, ataxia, and areflexia, then you would have the triad of Miller-Fisher syndrome. So yeah, that was something, as we heard what happened on each successive day, that progression, that was something I was thinking of, and glad to hear people in the chat are connecting those dots as well. Okay, and I think that's a great discussion. Okay, anything, John, to fill in the southwest corner there, or are we going to move on to the exam in the next aliquot?
There is another blurb, but we can kind of do it pretty quickly. It's kind of just like pertinent negatives and some other history that helps.
Sure.
So she endorsed some fatigue in her legs that did not worsen by the end of the day. She reported that her eyes are tired more than usual, but the diplopia does not worsen at the end of the day. She did state that her daughter noted some eyelid drooping bilaterally, but she never appreciated it on herself in the mirror. She denies facial droop, dysarthria, dysphagia, any voice changes, or loss of vision. She does report a recent persistent bout of congestion and postnasal drip that she went to her PCP for that last week. We are from Erie, PA, so Lyme disease is a big deal. So she reports a tick bite that occurred in the last month, but without a rash. She has no history of stroke or cardiovascular abnormalities. She has no history of cancer or autoimmune conditions. And only pertinent family history is that her son has Crohn's and her daughter has type 1 diabetes.
Excellent.
Do you want labs now, or do you want to chew on that?
Yeah, I think I'm looking at the time. I think let's pause for a second. It won't be as long as our previous aliquot discussions, but we were sort of converging on an acute polyneuropathy moving into this aliquot. Valeria or Madalena, anything in this help you feel more confident in that? Anything in this make you feel less confident in that as we go into the exam?
I think the fatigue buzzword definitely makes me think about more like a muscular junction, but that might be just my brain trying to take multiple option tests. And otherwise, I think well, the tick bite, of course, but I'm not sure that's an epidemiological determinant factor to think about Lyme. But that's for sure not differential at this point, I think. So I persist with the idea of neuropathy.
Yeah, the fatigability. We sort of say, oh, did we steer down the wrong path here? But it sounds like it's a little bit. The daughter thinks maybe there's some there. The patient's not sure. But yeah, we have to think about neuromuscular junction disease. If there was one thing in that box of history that moved us away from neuromuscular junction disease, anything there that you would highlight that doesn't really fit, and that's a prominent symptom for the patient? In other words, a symptom that if this is, we were fooled and now we see the patient and they have fatigable asymmetric ptosis and fatigable weakness on exam, we can talk about how to check. And we say, oh goodness, we got fooled, it was myasthenia. What's one symptom where you would say, well, hold on, this doesn't make sense. Shouldn't see this in myasthenia.
Maybe the fact that it's not worse at the end of the day.
Yes. Yeah, it depends what the patient's daily kind of schedule is, but okay, yeah, but there's one more kind of localizing feature there in the symptoms we've spent a lot of time discussing that. So diplopia is fair game, right? Some fatigability is fair game for myasthenia, but if you have a pure neuromuscular junction problem, are there any of those symptoms where you'd say, well, that doesn't fit with the neuromuscular junction?
I'm really not sure.
Yeah, I'm not sure either.
Yeah, it looks like Sridhara, if I'm pronouncing that correctly, is noting the sensory problems, right? So this is a neuromuscular junction problem, right? So we should see motor, but we shouldn't see numbness, tingling, unless, it's a little bit of a stretch. The patient's weak in describing that using the word numb, but the tingling, no, you shouldn't really see that, right? So that wouldn't quite fit to have sensory concerns with that. Although sometimes, as you heard me say before, you have this big constellation, it's hard to put it all in one bucket. And you say, what if I just take one thing out? Does everything else add up to something? And if it does, then what do I do with that other one? Do I toss it? Do I put it back in as something else? As Madalena said earlier, do I just say this doesn't, I can't make sense of all of these, but I can make sense of, 4 out of 5, and that's going to add up to my syndrome. So going into the exam now, if you were going to, what sort of things would you want to check here to try to make this distinction? So we think we're seeing some type of neuropathy. We still want to see which eyes are going in which directions, because we spent a lot of time talking about that piece, and we'll want to make sure we have some clarity there. What would push us more in the neuropathy direction? What, if anything, would push us more in the neuromuscular junction direction here if we leave out the numbness, tingling in considering that? If you were each going to pick 1 or 2 things on the exam, and you can't say, as people love to do, well, my one thing would be the neuro exam. Yeah, I agree with you. We'll do the whole thing for sure. But if you were trying to make this distinction, is this a neuropathy or is this a neuromuscular junction problem? What's 1 or 2 things on the exam that are going to help you there?
I think for me, maybe the reflexes, because in myasthenia you wouldn't expect decreased reflexes, and in neuropathy you would.
Yeah, perfect. Yeah, so in myasthenia, the reflexes shouldn't be affected. In Lambert-Eaton, I've never seen a case. Raise your hand if you've seen one. It must be pretty uncommon, or maybe we're missing it, but that's a presynaptic neuromuscular junction disorder. Myasthenia is postsynaptic. And they actually do lose their reflexes. And apparently, if you exercise them for a little bit and then check again, the reflexes come back. So a sign I've always wanted to see, because I don't know another condition that does. It's the opposite of fatigability, because it's presynaptic. You get actually sort of facilitation. But yeah, if we saw absent reflexes here, especially if we have some previous exams saying they were there before, that would push us much more towards neuropathy. And there's probably one other thing that would be helpful going along with what we said with the history, that if you saw abnormalities there, that would push you away from myasthenia, aside from the reflexes. I know these are a little guess what I'm thinking, but. So for example, you could get weakness in both, you could get some eye movement trouble in both. What would help you distinguish them? Yeah, go ahead. I'm sorry, Madalena.
Oh yes, just clarifying your question, distinguishing between neuromuscular junction and peripheral nerve. Is that what you're asking? Yeah, okay. I guess, yeah, I'm not entirely sure. Vale mentioned a great point about kind of the reflexes. And someone also mentioned in the chat, like, I think the motor exam and looking to see is this fatigable weakness or not would really clue us in on the neuromuscular junction, which shouldn't be present in a peripheral neuropathy.
Yeah, how would you check for fatigability? Do you have some ways of doing that?
Yeah, great question. Let's see. I mean, I'm wondering, like, if you're checking kind of like the shoulder length and you're pressing down here. I don't exactly know, but if just a guess, it would be kind of just to check their motor strength of, various muscle groups, and kind of holding the pressure down to see if after a certain period of time or with repetitive movement, it gets worse. It's just a guess, but.
That's not a guess. That's, you logicked it out and you came up with the perfect answer, right? So one test we do is if the patient has full strength in their deltoid, for example, on either side, then you say, okay, put this one down and 50 chicken wing exercises here. And you count with them and you get pretty tired, and then say, let's go again. And now I decide that it is fatigable. And that's one place. Not all patients have extremity problems with myasthenia, but often they have eye problems. So if you see ptosis, it's very hard in older patients. They get lid dehiscence. They can have sort of redundant skin. Is there really ptosis there, or just kind of some skin thing going on? You can have them look up, and I tell the patients, it's what we call the most boring test in medicine for them. For us, it's interesting, and just say, stare at the ceiling for a minute. And you'll see one side come down as like a curtain. I guess it's those muscles are, as we know, as we're falling asleep at the end of the day, right? Those eyelids come down, right? And so if you try to have them look at the ceiling for a long time, you might see one come down like a curtain. So just as you said, Madalena, sustained muscle activity or fatigue it out with exercise. Perfect. And there's probably one more thing we would look at here, particularly given the patient's symptoms, that we'd be checking. I know we'll do the whole neuro exam, but that we'd be checking that would also maybe be present in neuropathy, though not always, but really shouldn't be an issue in neuromuscular junction. Any thoughts?
I mean, I think just any sensory abnormalities, right? So just decreased sensation. Yeah.
Just like the history, right? Yeah. Now you can get a pure motor neuropathy, then you could really get confused between these, is it a motor neuropathy or motor nerve condition, motor neuron disease or neuromuscular junction? But on the flip side, you shouldn't get sensory problems with a neuromuscular junction disorder, right? So if we see areflexia and sensory difficulties here, then we'll be able to say that tiredness, well, she's getting weaker every day. Maybe she feels more tired, but it's not, hashtag fatigability for, buzzword for myasthenia. Okay, we budgeted our time in such a way that I think we're so close that the rest will come quickly. But if John has 4 more twists and there's some type of some red herrings to throw at us, I will apologize for budgeting time poorly here. But let's see how we do. Can we hear the neurologic exam, John?
Yep. Right before the neuro exam, just for sake of time, all peripheral neuropathy workup lab-wise was negative, other than an ESR elevated at 35. If you have any other questions about what we did a lot, but pretty much everything came back negative on the same day. So exam-wise, I'll kind of stay close to pertinent positives for sake of time, but mental status was completely normal on exam. Cranial nerve-wise, pupils were equal. They were reactive. Her visual fields were full. Now, on exam of just looking at her eyes, you can see her right eye was a little off midline, a little to the right off midline, laterally to the midline. When she was stated to be at normal straight gaze at midline, her eye was a little skewed to the right. On exam of the extraocular movement, she did have full movement, but on all the way left gaze, that's when her diplopia was the worst. And on right gaze and on any other gaze, she did not have any diplopia or just kind of mild diplopia relative to that left gaze. All other cranial nerves were intact with no issues. If you want any specifics, you can ask. Just trying to save time. Motor-wise, she normal muscle bulk and tone, and she had no abnormal movements. Strength-wise, everything was 5 out of 5, including neck extension and flexion. Reflex-wise, throughout, all were 0. And she notes that she typically has strong patellar reflexes. She actually braced for the strong reflex, and she was almost surprised that it was 0, and it actually really alarmed her. That's kind of where she was like, okay, this is something. Sensory-wise, in her bilateral lower extremities below the knee, she was diminished to pinprick and temperature, but intact to light touch, and she had a reduced proprioception at her toes, and no extinction, double simultaneous stimulation. On coordination exam, she had ataxia in her hands on finger to nose through all movements, with no change as she reached her target. It was ataxic throughout. Heel to shin was intact, however. On gait, she wasn't completely ataxic, but she had some corrective steps as she was walking on heel to shin and normal walking. I think that's everything we did.
Perfect. So Madalena and Valeria, where is the problem? What is the problem? And if you had to prove it and had all the resources at your disposal to do so, how would you prove it? Feel free, either of you, to take 1, 2, or 3 of those questions in our final moments here.
Yeah, so I think this was probably a neuropathy, and I will rule it out with some antibodies because we're thinking about Fisher variant, G1QB maybe antibody, something like that, the gangliosides. And then I think there's other ones, but I think those are the most like associated with the Miller-Fisher variant. Just because of the reflexes that confirm our localization to the peripheral nerves rather than the neuromuscular junction. And yeah, I don't think there's any other way to, because I think Guillain-Barre is more like a syndrome. You don't really confirm it with something like, I guess we could do nerve conduction studies to see, okay, this is a peripheral neuropathy, or like broad demyelinating variant, but otherwise, I think syndromically, that will be it, or
Yeah.
I'm not sure.
Yeah, especially in this case, right? You have a patient who knows they have reflexes and they've lost them quickly like this and has the rest of the picture. You probably could be pretty confident if you wanted to prove particularly, so there are these ganglioside antibodies that not all variants have, but there is this GQ1B variant, but you send it and it'll probably take weeks to come back. So probably not gonna be able to make a treatment decision based on that. You could do nerve conduction studies, right? And prove that there's a acute neuropathy. Sometimes the neuropathy is so acute that the changes are not yet seen and you have a normal nerve conduction study. And there's probably one more test you could do. Just, this seems pretty clear. I'm trying to think, would we do it anyway if we saw this? You could probably say we don't really need to do it, but if people really want to be by the book and say, I just want some objective proof, and the GQ1B could take weeks to come back, if there was one other test you could do.
I'm not sure if this is what you're getting at. Then I think some people put in the chat, you could get in LP, and I believe in Guillain-Barre you have, elevated protein, but normal white blood cell count.
Yeah, perfect. Or at least albuminocytologic dissociation, meaning the protein is high and you might see a few cells, but it shouldn't be really high like you'd see in an infection. So you see sort of protein elevation out of proportion to cell count. Just for teaching purposes, do you know what types of things you might think about if you did see a lot of cells? You said, this really looks like Guillain-Barre. Let's say it's not one of these variants where the eyes are involved and all that stuff. And you say, oh, there's 50 cells. I wasn't expecting that. Anyone know what could give that picture of the syndrome of Guillain-Barre, but oops, they're cells. It's not an idiopathic inflammatory condition. I don't mean 6, 7 cells. I mean, 50 or something like that.
I'm not sure.
Yeah.
Me neither.
Okay. It's something you both said, actually. So Lyme disease can cause a acute sort of polyradiculoneuropathy, and it's infectious. So you would see some cells. And then reported, though I've never seen it, HIV at the time of seroconversion can cause a meningitis, can cause facial nerve palsy, unilateral or bilateral, or can cause a Guillain-Barre-like syndrome. And the hint is that, oh, they're cells. This is not post-infectious, this is infectious. So if you see Guillain-Barre and then you get a whole bunch of cells, and then rare and probably wouldn't be this fast, neurolymphomatosis, when lymphoma infiltrates roots and nerves. You can see something that looks like this, but you'd probably have some cells that you'd have to explain and would know it's probably not just the garden variety idiopathic syndrome. So yeah, that could be one way to prove this, because you're going to be thinking of some relatively strong treatments and you might want to feel a little more certainty. So before we talk about that, since we spent so much time talking about the eyes, which became less relevant, but there were such big smiles to the chief concern of diplopia that I thought it would be, people really wanted to talk about it. By the way, so let's just say, by the way, what muscle and/or nerve are affected in this patient now that we heard the exam?
So it's interesting. So I was kind of trying to visualize it as John was describing it. So the right eye is off midline laterally to the right. So when I think about that, either the right lateral rectus is, overactive, or the medial rectus is weak. That's kind of how my mind is explaining it.
That your mind is explaining it absolutely correctly. Yeah. So the eye is a little bit off the midline in the horizontal plane. right? So most people would think of medial rectus, which is true, but good for you for thinking, or it could be some type of restriction in the lateral rectus, as in thyroid eye disease, right? And there is actually a third possibility here, something we talked about. So if one eye is abducting and the other eye is not adducting. So we heard that the patient having more trouble looking to the left. So if we knew that without looking, we'd say, oh, either the patient has a left lateral rectus /6 problem or a right medial rectus /3 problem, or
MLF problem.
Or an MLF problem. So 6 isn't talking to 3, right? So I always do this to try to figure this stuff out. So we heard that the right eye is a little bit off. And when the patient looks left, somehow the right eye is not coming along. So is it a partial third if everything else is okay? Is it a medial rectus problem, or is it an INO? And now that we see all the peripheral nerves are affected, we're going to say it's probably some type of partial third. And maybe John will tell us, as this patient evolved, they lost more eye movements, because the triad is ophthalmoplegia, right? The patient can actually lose all their eye movements, but they might not and just have some eye movements out. All right, so I agree with you. This sure sounds like Miller-Fisher syndrome. And with all these things pointing at it, would you even need the LP and the GQ1B? They seem a bit academic, and probably, given the level of disability, you would treat the patient. And how would we treat the patient, Valeria or Madalena? And then John can tell us what they did, or if they found something different and we're all wrong, what they found. What are the options?
That's something that I actually wanted to ask you, because I know that people have preferences between IVIG and plasmapheresis. So I don't know. I guess the comorbidities of the patient would influence if we do Plex or IVIG. But if there's no contraindication for IVIG, for example, what do you think? Like, is there a preference? Is one better than the other?
Yeah, clinical trials have shown they're equivalent. They have different risk-benefit profiles. IVIG you can give through a peripheral IV. Plasma exchange, obviously, need a central indwelling catheter. Plasma exchange feels more aggressive because you're taking the patient's plasma out and cleaning it off, and you have the central line. But at least according to the trials, they were seen as equivalent. IVIG can cause some hypercoagulability. So maybe if the patient has a history of DVT, PE, or other hypercoagulable states, maybe that would give you some pause, or the patient has some type of cardiovascular disease and you're worried about taking their plasma out and putting it back in and all this stuff. These types of things might influence you, but in principle, they've been shown to be equivalent. And then one important thing I always like to mention, so people know, and also when we tell families, the patient's not going to get better right away, right? Because the nerves have suffered some damage in the demyelinating variants. There's demyelination, and it takes, I forget the number, maybe somebody knows, or somebody knows in the chat or can look up how fast myelin grows, but it's like a millimeter every few days or something like this. So the way I explain to families treating this, patient's probably not going to get better in the hospital. This treatment is going to throw water on the fire and put out the fire on the nerves, but what's underneath the fire is the wood that's been damaged, but different than wood, then the nerve is going to grow back. And even patients who are intubated with Guillain-Barre syndrome and very severely ill can make a full recovery. They don't always, but they can. But often they leave the hospital. The nadir is usually at around 2 or so weeks into this illness. So they may actually be getting worse while you're giving the treatment. And families are wondering, you tried IVIG, it didn't work. Should you do plasma exchange? Well, no, then you're exchanging off all the IVIG you gave. They'll say, oh, we did plasma exchange. Should we do IVIG? I think either this is being studied or has been recently studied, and either redosing IVIG or doing one and the other. Like I heard about this recently and haven't pulled the paper yet, but either is being studied or was recently studied. And my understanding is that the punchline is there's no real advantage to doing that. You have to stop the inflammatory process and then give the myelin time to heal. In the axonal variants, if you have true axonal death, then some of those patients do less well. I would think, with this being a ganglioside-associated one, that this is one of the demyelinating variants, but I'm actually not 100% sure. So yeah, I would suspect, unless John has some other tricks up his sleeve here of what happened to this patient, or they saw a whole bunch of cells on CSF, or they got an MRI and found things that we weren't expecting to see, that This certainly sounds like Miller-Fisher syndrome, so nicely done, all of you. And hopefully patient got some IVIG or some plasma exchange, John can tell us, and hopefully made a full recovery. But tell us what you found and what you did, and if we were on the right track here, John.
Sure. So on her presentation, she did get a CT head and MRI head ordered by the emergency department, and those were both negative. With our exam in mind, we of course were thinking along the lines of Miller-Fisher. We were pretty confident of the diagnosis, but we did give her the option, say, if we got an LP, it would help confirm the diagnosis. But based on her exam and history, we are almost 100% sure that this is what's going on here. But she actually elected to wait before starting IVIG to get the LP. So we did end up getting the LP. This is all kind of real time. We did the LP today. And it did come back actually like 20 minutes before this, I think. It's like 8 o'clock here. And it came back as elevated protein in mild elevation in white blood cell count, but we did some research and it still is possible in Guillain-Barre or Miller-Fisher to have mild, either early elevations. So we did conclude this as Miller-Fisher, and she's starting her 5-day course of IVIG today. We did, since anti-G1QB is one of the few antibodies that you actually get serum wise, we did send it out for academic purposes. So that's pending just to see if we get that. Excellent.
Phenomenal case, John. And I love that it's real time and the labs are coming back in real time here. And right, as we said, cytoalbuminologic dissociation or albuminocytologic dissociation, it's a dissociation, right? You can get some extra cells in there because it's inflammatory. It just shouldn't be a lot of cells. And I'm being deliberately vague because it would depend on the clinical context how much we'd say, yeah, I think we're okay with that, or that's a few too many cells to feel comfortable. And we're looking it up as you did and looking at case series, et cetera. So thank you, John, for bringing this case and presenting it. Valeria and Madalena, phenomenal discussion. And I great shout outs to folks in the chat who were very actively participating with some great points as well. And this would be a good companion case to Maria's case that looked like Miller-Fisher syndrome, except the patient was confused and had altered mental status. Anyone know what that's called?
Bickerstaff encephalitis.
Bickerstaff encephalitis. Yeah, exactly. So
I remember that case.
Yeah, it was an amazing case that we were all saying, wait a second, doesn't all fit together, until someone said, without the altered mental status, wouldn't it just be Guillain-Barre? And I said, oh, it's Bickerstaff. I see what you're doing here, Maria. We got it. So we'll have to retweet that one around because that was a very interesting one. And you might say, but isn't Guillain-Barre a peripheral process? What's going on in the central nervous system? Actually debated by one of my mentors, Alan Roper, and another group about whether it's truly a central lesion or these very sick patients with Guillain-Barre syndrome are delirious and in the ICU, and there's not truly a central lesion, and they debate what's actually seen in the pathology and all this stuff. You can find it in the literature if you like watching neurologists debate these types of things. But it's a real thing. I have seen it. And the MRI was normal, and the patient otherwise had Guillain-Barre, but had altered mental status and recovered. And so did Maria's patient. So it's out there. So Miller-Fisher is ophthalmoplegia, ataxia, areflexia. Bickerstaff is that plus altered mental status. And just also know these variants are not totally clean in practice. So sometimes you'll see patients that have a pure motor or a pure sensory, a pure Miller-Fisher, but sometimes there's some overlap. I saw a patient with a very rare variant, facial diplegia with acral paresthesia, it's just what it sounds like, bifacial palsy, painful paresthesias in the hands and feet. And actually told the patient, this is very mild, you can still walk, I wouldn't give you the risks of the treatments. And the patient went to a different hospital wanting the treatments, and in that hospital developed difficulty walking and Miller-Fisher syndrome on top of this, and got IVIG. So these can change over time, where they can sort of overlap. They're not always totally pure. So fantastic. Well, this was a lot of fun. I'm sorry we went over, but we have a pretty good 15 out of 18 retention. So hopefully people enjoyed it. We still have teaching points. We still haven't taken up the whole screen with them. So maybe I should keep going. We didn't talk about vertical diplopia. No, I'm just kidding. Shayna, tell us what some of your highlight teaching points are, and we'll go from there.
Okay, so thank you so much for this amazing case. Also hearing about diplopia is my neurophobic chief complaint, but I feel more happy to have learned about it. So my highlight teaching points are, so we're differentiating between monocular and binocular diplopia. If it's monocular, think of a refraction problem. If it's binocular, it is usually a true diplopia due to misalignment. And then another thing is, what I learned is, we also learned that the medial longitudinal fasciculus is the important connection between the sixth nucleus and the contralateral third nucleus. So if there is a lesion of the medial longitudinal fasciculus, think of this internuclear ophthalmoplegia, which is common in diseases like MS. And then we learned about diabetic neuropathy, that usually we don't see any affection of the pupil, because it has something to do with the anatomy. So the fibers that are controlling the pupillar reflex are superficial, and during a microvascular lesion, this is usually spared. And then we learned about the bucket of diplopia and numbness and tingling, and we had the buckets thinking of inflammatory, like Guillain-Barre, botulism, infections like Lyme disease, and also heavy metal. And then we talked about Miller-Fisher syndrome. We have this triad of acute ophthalmoplegia, ataxia, and areflexia. And we also learned about the differential of if there's a Guillain-Barre-like syndrome with cells in the cerebrospinal fluid, think of HIV during seroconversion or Lyme disease. And if you have Miller-Fisher-like syndrome plus altered mental status, think of Bickerstaff encephalitis. And we also learned how to differentiate between neuromuscular junction disorders and peripheral nerve disorders. So usually in neuromuscular junction disorders, we have fatigable weakness. And in a neuropathy, we usually have areflexia and sensory abnormalities like numbness and tingling. And think of the, like, as we know, Miller-Fisher syndrome can be treated with immune globulins or plasmapheresis, and the complication of these immune globulins, they can cause a hyperviscosity like syndrome leading to thrombosis. Yeah. Thank you so much.
Fantastic. Well, thank you for keeping track of all these teaching points and highlighting some of those, which was very helpful for us. And thanks again. It was great to see everyone. We'll try to do this once a month or so. So save up your cases and your excitement to discuss. And thanks again, John, for bringing the case, Valeria and Madalena for brilliant discussion, chatters for a brilliant discussion as well, Maria for scribing, and Shema for these teaching points. Have a good day.
Thank you. So much fun.
Thanks, guys.
Take care. That was fun.
Thank you.
See you soon.
Miss you guys.
Bye.